Okay, good morning. Our numbers are still going up, but we'll get started in the interest of time. So thank you all for joining today and for jumping on the rescheduled day. I've shared with a few people, but I wound up having emergency gallbladder removal surgery. So on the actual day of the webinar. So quickly moved things around. So nobody apparently wanted to take my spot. So instead, we just, were able to push this back 2 weeks. So apologize for the last minute change. Never had that happen before. So, but here we are. Thank you, everybody, for finding this and being able to accommodate the last minute change. So do appreciate that. Here is our agenda for today. Sort of similar, but we'll do some OMSAS updates. Punt it over to network for any updates there. We have some clinical focus, clinical corner focus. We have a provider spotlight today, some kudos, some clinical updates and reminders, some call outs for Availity specifically, and then some additional resources, next webinar, etc., things like that, as well as some questions, which I did want to point out. So when we somewhere around when we switched over from Zoom to Teams, I did switch some of the options. So the Q&A is available to put your provider questions in. The chat feature is disabled, but there is still a mechanism to put in questions. So wanted to make sure everybody was aware. I think it was being used, but I just wanted to put another, shout out about that just in case we have some newer folks that are joining the webinar. So feel free to use that. So some state updates since we last met. So it looks like the state had been working with some early intervention providers, et cetera, and they have outlined some sort of like talking points. I know we've had questions along the way, and I'm sure if you're newer to IBHS, it comes up on occasion about how IBHS and like those EI type supports, the OT speech, or even in the outpatient setting, PT, how that works with serving the young member. Should it be at the same time? Should it not? How does all that work? So there's a couple of sort of, I guess, talking points, for lack of a better word, that are outlined. I thought this was a really great, synthesis and response, because again, it comes up, every quarter probably from a provider or two. So I thought these were good food for thought to take back to your leadership, or as leadership to continue to take back to your team. There are a few examples that were given that I thought, again, highlight some things. So I'll talk through some of these, and then the examples I'll kind of let you on your own accord here. So they're calling these the other related services. So the ORs are professional services delivered to address specific needs. But they do have, as they're saying, varying levels of understanding when it comes to like behavioral health and the appropriate processes. So they should be concerned, obviously, with the holistic, looking at the team meetings to assess that, everybody is contributing accordingly. If there's some speech-related concerns in the treatment plan, how can we work collaboratively? Who takes that lead? If they appear unfamiliar or uncomfortable with the behavioral health needs, that doesn't necessarily warrant the need for IBHS during their service provision necessarily. That may require some more discussion and support. So if it is kind of believed that IBHS may be needed to support in some way during their actual service delivery of those services, the treatment team, you would need to specify that behavioral health need, clarify obviously how they would be supporting, how are they going to transfer skills, what would that, just being collaborative isn't necessarily sufficient. All of that would need to be worded and constructed within the treatment plan, obviously, so people looking at the treatment plan can see obviously the reason that somebody IBHS is supporting in that setting. IBHS may not be billed during a session simply because you're kind of there at the same time and they're already being served. It needs to have a conscious thought if both are there at the same time that there's a treatment need and that it's clearly documented, supported, articulated, planned for in the treatment plan and the treatment service provision. You know, we can't tell an ORS professional that they can't see a staff because they're already with the child. Obviously, if they are recommended and prescribed, it is important that that member receives that service as well. So there needs to be some more, you know, coordination around planning and timing and support. Here's, I think it's 3 slides of some examples. So I'm just going to pause and let you read, but then of course these are always posted after, usually a day or 2 after our webinar is finished. Aubrey is able to post it on the web, so you can obviously take, you know, spend more time with it. But I will silently let you guys read for a minute the scenario and the thought process behind that. Another scenario involving an occupational therapist. And an example with a physical therapist. As I kind of said, I don't think any of this is new. It's nothing new. I think it offers some nice clarity around a topic that sometimes feels, you know, sticky, gray. So I wanted to make sure I passed some of this information along. If there's anything that comes out of this that you have additional questions or clarity on, you know, I'm happy to try to work it through, or if there's something that we both can't figure out, we can obviously, you know, ask for some clarity from the state as well. So hopefully that was a little bit helpful. I did also want to offer some update. You've seen this slide before. We've talked about, you know, primary insurance issues that are happening and continue to happen. I don't feel like anything is particularly new, although I do feel like there are more and more challenges and, you know, providers that are stopping to accept that, which is definitely impacting the members. So in our OMSAS BIMCO meetings, we have been talking about, all of the BIMCOs have been reporting this same scenario, the impact that it's having on you guys as the providers, and certainly on the members as well, accessing services, etc. So that was discussed at one of our, maybe it was the end of the year meeting. So I kind of volunteered and put together a bunch of the information from all of the BIMCOs. So everybody emailed me some of the information. I was able to synthesize it, sort of highlight where a lot of the issues are occurring, and then the outcomes or the impact that it's having on the members, on the providers, financially, accessing services, etc. I was even able to call out a few of the primary insurances and kind of articulate some of that. I did pass that on to the state, and before we had our last meeting, they acknowledged it. They thought they had some opportunities where they could use this information further, and they did have a request out to the insurance department to double check on whether there were in fact some complaints formally lodged and how we can sort of talk through that a little bit more. She had not gotten a response yet, but was hoping for our next meeting, and we did put it on our next meeting agenda. So we are continuing the conversation. And again, this is a statewide issue that appears to be happening. So all of the BIMCOs are also expressing and passing along all of the provider concerns. I do continue to encourage families when we talk to them, and when you guys talk to them, and providers, to do this, so that there is something formal that we can put note on. Perhaps they are able to follow up and make some resolutions with the individual insurance companies. That has yet to be clear to me, but I want to stay a little hopeful that there may be some movement and momentum. So I should have a little bit, maybe more of an update at the next webinar after we have our next OMSAS meeting. But there are things happening in the back end to try to help you guys as providers who are really struggling, understandably, with the lift and the requirements around this, and some of the really honestly negative outcomes that are happening for the members who are able to access the services as well. So did want to let you know that there were trying to do the advocacy and see where we can go. So I will, of course, keep you posted. I always appreciate any specific input. Just to have some examples is kind of handy when I am talking with the state, or if they come back and ask some more questions. Not that I can actually resolve per se, but sometimes, again, having actual examples and different scenarios can be helpful to help articulate and highlight the issues. So continue to pass this information along, or utilize it as well as in your agency. So the other thing that has come up in our sort of state meetings, and I do hear it on our end as well, so I thought probably a good time to do a reminder. Again, we have staff that change all the time. But even the state licensing is involved in, like, the regional offices are involved in those meetings, and they hear the same thing as far as, and they say they respond the same way. So the regulations are minimum standards. They always say, like, it's the basement, so it's the lowest level of expectations. And then the behavioral health MCOs may have a higher standard or expectation. For instance, the regulations talk about 1-year authorizations or 1-year spans. Magellan has been putting in the 6-month time span. So but that goes for other things. I know we've heard feedback like, well, when we get our state licensing, nobody has pointed out this issue to us. And again, some of it may be okay by the regulations, and it may be sort of more of a clinical best practice and a standard that Magellan is looking to meet, that the regulatory body may not point out or say is, like, not in compliance with the regulations. So just a food for thought on that, because sometimes we do hear that that our feedback may not, that's not what they're hearing from the licensing. So if anything obviously seems overtly incongruent, we certainly can look further about that. But typically when I hear things, it's more that, we maybe have a different expectation than the regs. So just to point that out as well. And I didn't double check, but I'm assuming Crystal is on the call. Yes, she is. There she is. Okay, so I will turn it over to Crystal from Network for some updates.
Thank you. Good morning, everybody. Just a couple of updates from Network, nothing really glaring. As always, our first slide is just a breakdown of our team by county and contracting and credentialing. Billing usual and customary. So I know we talked about this before with submitting claims to use the usual and customary charges versus your contracted amount. This is in the event that rate increases are sent out to providers. Sometimes those are backdated. So when claims are in the system with a lower billed amount, usually claims aren't able to be captured and adjusted. So we're hoping providers can start billing those usual and customary charges so that when a rate increase is provided, we can just go in, sweep those claims, and they can pay at that higher amount. Just a couple billing reminders. No billing the member's home address or any location other than what's listed on your contract. They are listed and have your specific MIS on those as well. When billing, use your contracted codes and modifiers. Auth codes may differ from what's listed on your fee schedule, and just be mindful that the modifiers must stay in the order that they are listed on your fee schedule as well. For any corrected claims, it's required to submit those corrected claims with the original claim number on them. And for Act 62 covered members, claims do have to go through that primary payer first before submitting to Medicaid, who is always the payer of last resort. Claims resolution. So for claims that you feel were denied incorrectly or you may have questions about, these are considered claim inquiries, and they can be called in through our provider service line. They can review them over the phone with you. And then if needed, you can submit what we call an SRA or a service request application. Those get sent to our claims team, and they're handled in real time. So usually they take about 24 to 48 hours to be reviewed and possibly resolved. Satellite sites and licensing. Again, this is just a reminder that their licenses are issued regionally. The 4 regional offices, Western, Northeast, Southeast, and Central. You do only need 1 license if you have multiple locations in 1 region, but if you have services in multiple regions, you would require multiple licenses. You do need to have the service description include all of those locations under your regional license, as well, and what services are being provided, for example, home, community, and site-based. You do only need 1 service description for each license. If there are any changes, you do need to update your service description and submit that to the licensing office for approval. And if a provider's address changes, a provider must notify the licensing field office. And if you are enrolled, you must update your MA enrollment as well. And just note that all locations do not require enrollment unless you are providing on-site services. For expansion, Magellan is continuing to evaluate our network needs. So when there is an immediate need for expansion, we will reach out to providers. We are regularly reviewing and prioritizing both the new applications and existing applications that are coming into our inbox. Magellan and the counties are hoping to have finalized decisions based off the 2025 projections and 2026 capitation rates. And decisions are individual by each county. Any opportunities for rate adjustments or network expansions, Magellan and the county will direct providers directly. For the new, not really, I guess, new IBH process, but our still intact IBHS group process. If you're looking to add a group, ABA group, or both, you can reach out to our interested provider inbox at the email address here. We will respond by sending our expansion application. Once that's submitted, it will go into our review process. And similar to the previous slide, we will reach out in the event that we are able to move forward, or if it's something that we would not be able to move forward with at the time. For any moves, adding locations, wanting to start one-to-one services, stuff like that, same process. You would reach out to that interested provider inbox. And again, we would send that application and it would go through our internal review process. And as mentioned before, we are continually reviewing and prioritizing both our new requests and existing provider requests. This slide just contains the information for Availity contact. They're available either online or chat or via the phone. Just some network reminders again, credentialing is updated every 3 years. Typically about every 6 months prior to your recredentialing date, you will receive information from our CRED team, an updated CRED packet that would need to be submitted back. So just please make sure your contact information is up to date on our system to make sure that those CRED applications are going to the correct person. Promise enrollment is revalidated every 5 years, and that can the revalidation date can be found directly on the Promise website under your Promise number. We do encourage providers to review, keep this date in mind because providers are responsible to revalidate those as needed. And this is included for all enrolled locations and for all provider type specialties. And just a reminder, without active enrollment, claims can be potentially affected for reimbursement. For out of network, when referring or transferring a Magellan member, please ensure the provider is contracted and networked with Magellan. Magellan's policy related to non-par requires that all in-network options must be exhausted first. To start referring a member or family to an out-of-network IBHS provider without talking to the family about this critical component can lead to delays in future services. So please include Magellan or your care manager if you are looking to refer a case. And that's it for network. Thank you, everyone.
Thank you, Crystal. All right, moving on to our clinical corner. So we realize that we are approaching the summer time frame where summer camps, ESY, all kinds of BHT changes are hitting their time frames. So, and are coming up shortly. So a few slides that we wanted to talk about on an administrative end on how to keep it in a way that your care manager can easily read and understand what is being requested, some expectations, best practice, etc. So I'll highlight a few and then I'm going to pass it on to Dr. Torres O'Connor, who is going to highlight a few others. So one of the questions that comes up at times, if the child is receiving services in multiple settings, do assessments need to be conducted in every setting that IBHS will be provided? What about those summer camp settings? So this is actually from the state Q&A. And so their response was the child should be assessed for each service that will be provided. The child should be assessed across the homeschool and other community settings. If the child is attending a camp, the graduate level professional should determine if the existing community assessment identifies the child's needs in the new environment or if an assessment in the new environment is needed. So I'd like to call your attention as a reminder on that one. And then I think this is from one of our FAQs. So can a BC observe the client how can the BC observe a client in a setting where the BHT services will be provided if the setting has not yet started. That's another common one. So if it's not possible to gather the data in the actual setting, the data should be obtained from a similar setting. Equally as important would be to include as much information about the camp or the program as possible, including the schedule, number of participants, a staffing ratio, previous experience in that setting if applicable. If they went to that summer camp last year, that is so important information to share on how they did, how services went, if they were receiving that kind of support, if they weren't receiving the support, how did it go? That information is all very critical. Saying that you provide support in school and making that as comparable to a camp support needing is not necessarily the equivalent, right? School, sometimes the level of support, the triggers are academic based. And that wouldn't necessarily translate to a camp that doesn't have an academic component to it. So being able to specifically point out the needs and the data around that and how that would compare to the maybe a summer camp with a different expectations is very paramount to having us review and being able to support the medical necessity. So some of the things and tips. So the camp details, the name of the camp, how often are they attending? What are the hours? What's the schedule of the support? What kind of structure do they even have to their day? Are you looking at supporting for that whole day, or because of the certain activities you're looking to support at certain times? As noted before, have they previously been there? How did it go? Where did they struggle? What helped them to be successful? Document specific behaviors that would require the support within the camp setting. Again, I kind of just sort of pointed that out. Please differentiate hours per month by settings. This is so critical. If there's an ESY or in your 6 months, you're supporting in school and then it's stopping on June 5th, and then there's a little break, and then there's, this camp for 4 weeks, and then this ESY, and then back to camp. Those dates need to be as spelled out as possible. Obviously, that correlates with the number of units that you're going to request. But we've already seen 6 months requests where it just says school. And clearly, you're not going through June, July, August with a school prescription. So that already makes the care manager not know what exactly we're requesting. Does that mean ESY? Does that they just forgot to cut it off on June? So please make sure that that's as clear as possible. The ISPT meeting summary should include a representative from the school, from the summer camp. A lot of the directors are accessible, if not obviously the counselors may not be, but just assuming that you're welcome and that they understand what your role is not necessarily a good assumption. So that conversation, that meeting would be very important to highlight what the goals for this child are, especially if they were supporting previously this child and sort of being able to create an effective treatment plan. Please know this information before submitting the authorization request. If you don't have the information, so right now, I understand it's at that tentative time. Some people do, and some people do not have that information yet. You can submit your concurrent request and not put your summer request camp, let's say, in there at that time, and then submit a change of prescription request later once you have all the information. It's going to be much better for everybody that you have the information to be able to support the medical necessity determination. Without that information, it's very hard to be able to support that. And just make sure your paperwork is clear and consistent. We have some times where certain documents negate each other. The TAR doesn't necessarily correlate with what's in the assessment. We obviously have to go with the assessment, but it starts raising questions, confusion. And then if our doctors are involved, then it's another person who's also confused and trying to figure out what the requests is. And we've had a lot of scenarios where we get to maybe even a peer-to-peer, and it appears that the request has changed again. So again, if it's not clear when it's time to do an actual concurrent, hold off until you have that information and submit it via a change of prescription request. Now I'm going to turn it over to Dr. Torres O'Connor for some more information about that. Thank you.
Sure. Morning, everybody. And again, I'm sure Kristen says it a million times during these presentations. You can reach out to her, care managers, and myself if you have questions. I wanted to talk about preparation and considerations for the upcoming school year, which ideally should be happening now because it's almost spring. That's nice to say. So there's 4, I think, items, topics that I think are really important to touch on and talk about in terms of the first one being IBHS skills transfer training and generalization. Now it's end of winter, beginning of the spring. It's important to really start to emphasize the skills generalization because IBHS is really a type of train the trainer model of care. You as providers are the experts in behavioral modification, management, change, and your job is to transfer that expertise so that the natural supports become the experts. The natural supports become the first go-tos when a child starts to go off track. Not, oh, the child's going off track, we need to call IBHS back in place. And that's the importance of transferring the provider expertise to the caregivers and natural supports. That's why it's really important over the summer that supports and services continue because otherwise you are just kind of naturally, for most kids, going to have a regression. Academically, it happens. Behaviorally, it naturally happens. And I understand parents often want to say, oh, I want to give my kid a break. Most of the problems and the challenges are in school. They're not at home. But I think the main focus and the message that's important to give to parents is your job as a provider is to make them the experts, not for you to remain the experts. And in order to do that, you have to stay involved and support the mentoring and the coaching of the skills all year long and not just during the school year. Also, starting to look now that it's spring and talking to the school administrators in terms of who are the options of possible teachers for the next school year. It's possible that those teachers will not be there, but there's also a good possibility that they will. Introduce yourself to the teacher. So say Johnny's now in first grade, he's going to second grade. Principal says, oh, there's these 2 possible second grade teachers. We're not sure which one he's going to get. Introduce yourself to the second grade teacher. Introduce what you do, who you are, how you help, and that it's possible they may be getting one of your students. And what is it that means? What is it that you've been working on? What I've encouraged my staff when I was supporting programs was to actually have just a very general list of suggestions. You're not violating HIPAA, but a list of strategies that you're currently using with Johnny and to share it with the possible upcoming teachers because I've talked to many of you about, and you all know, the strategies that you're using with your particular children are not just for your kids. They're helpful for all the kids in a classroom. Also, to make sure that you're looking beyond the classroom for supports. And although I understand there's turnover everywhere, but looking outside the classroom in terms of who are the contacts and staff within special education, within psychology, nursing, school counseling, administration. Is there a teacher in the school that a kid really likes, that they gravitate to start to develop that community for that child and engage them as part of the natural supports and transfer of skills outside of the classroom. When you get to the higher level departments, there's less turnover. And this is not a guarantee, but this can be very helpful in terms of expanding the community outside of the classroom. So it's really important to be focusing on that this time of year. The other thing to keep in mind when you're looking at hours for the upcoming school year is normal maturation and development during the summer, especially for kids. So much natural maturation and development happens on their own. It's important to give our kids the opportunity for success versus assuming that the behaviors that they had at the end of the school year are automatically going to happen at the beginning of the school year. We want to be able to give our kids the space and the grace to be able to be successful, and to be able to be part and learn from their own maturation, natural development, human development. So it's important to be able to give them some space to do that. Also keep in mind the beginning of the school year, new teacher. Teachers in general are taught two things in school: classroom management, instructional control, along with the other expertise that they have. It's important to give a teacher, again, the grace and the space to use their training of classroom management and instructional control. If you're finding that a teacher isn't so great at the expertise that she or he or they are supposed to be, that's not an IBHS issue. That's a school issue. That's an academic issue. That's a teacher training issue that needs to be addressed with school administration. And then the last piece in terms of hours for the new school year to consider, it's important to consider all the things that I had just previously talked about. And also think about if there were no or there are minimal high risk behaviors at the end of the school year and over the summer, there is likely not going to be a need to start out the new school year with the high numbers that you ended with at the end of the school year. You also have to keep in mind schools have their own behavioral modification process through MTSS, and looking at what MTSS strategies is the school implementing if the child starts to have some challenges. The school has to go through that on a regular basis every year. It's not a matter of, oh, Johnny is at level 3 end of last year, so we're going to skip 1 and 2. That's not how that process works. They need to partner with you to do their part so that you can do your part, because at the end of the day, IBHS is meant to be the short-term support to the schools, and the schools are there for long term. So it's important to support the kids also at home. So a lot of times there's no home support over the summer. It's very helpful, and I would work with my staff to stress to the parents that the summer is not the time to roll it back. Okay, the summer is not the time to actually not have some hours in the home, because that actually is not setting the child up for success, because the parents aren't able to keep up on their mentoring and their coaching, and they're still learning the skills, and the child is going to also start to possibly regress as well, because the main goal, and to repeat it to all the natural supports on a regular basis, is for me as the provider to help you as the caregiver and natural support coaches to become the experts, not me. My job is to get myself out of a job because you now know how to do that. So doing all these elements, as I had said, gives the space and the grace so that the child has the opportunity to be successful in their own right, on their own from the start, versus assuming that they automatically need the same amount and degree of safeguards that they had at the end of the school year, which can often be an incorrect assumption. So making sure to look at your kid, and also frame it for caregivers and natural supports that the purpose of IBHS is to get kids on the right track with the support, to help the natural supports become the experts in behavior management, modification, and to become the first line of defense when the kid starts to go off track. Because kids are kids. They're not robots. Progress is not linear. There's ebbs and flows, backs and forths, but that doesn't mean that progress isn't being made. Oftentimes with progress, and you all know this, there's often a regression before there's a solidification and an advancement of the skill in and of itself. So regression can sometimes be part of the progress process. And just to make sure that you're talking to your caregivers and your natural supports about the importance of them becoming the experts and the importance of kids are going to be kids. They're going to go off track. They're going to do things that are not, that can be surprising. That may look like they're not making progress, but to not automatically assume that that means that they've made a complete regression, because the purpose is that they've become the experts in IBHS. And it can be helpful to keep framing for the natural supports. You're going to become the experts. My job is to help you become the expert in helping to address Johnny's behavioral challenges, to help give him the skills so that he is at or close to developmental appropriate stage given his, her, or their mental age. So I just wanted to put this out here because it's the time of year where we're starting to think about summer. We're starting to think about the upcoming school year, and to keep all of these things in mind so that our kids have the grace and the space, and the natural supports have the same grace and space to be able to be set up for success, and not have you as providers be the automatic default, because that's not ultimately helping anybody to be able to really gain confidence in learning the skills. The other piece to remember is, for the little guys, the skills that you're giving them, they are going to learn some of them on their own, but the expectation of internalization of all of the strategies that you're giving little guys is not necessarily realistic. Structure, routine, and frameworks come externally for children, and as they grow, they start to internalize those processes, which takes a long time. So I just wanted to put that out there kind of as a reminder, because I know you guys all know this. If you have any questions about it, you're having any challenges with it, please feel free to reach out. And I think that's it, Kristen.
Don't go away yet.
Yep.
we had one question that I wanted to throw at you, which is a little different than what you're talking about, but we were asked, could you clarify whether an observation during recess, lunch, gym class within a school would be a direct parallel to a camp setting? They said these situations generally have lower ratios of caregiver to children, rarely include academic triggers, have similar activities seen in camp settings, etc. Do you have any
So
thoughts on that?
I do. I think if the child has not been to the camp that they're going to be going to the previous year, then that may be the most equivalent environment that you have. But if they were at the camp the previous year, I think that's kind of something that you would use as your main reference point. The thing to keep in mind is, with kids, when they're going into a new environment, there's often, as you all know, a kind of a grace period, a smooth period. Things are looking relatively good. And then after a few weeks, when they start to get comfortable, then behaviors really start to happen. So keeping that in mind, that's a great opportunity for a BC to spend a good chunk of their time in the beginning working with the staff, reminding Johnny of what the strategies are helpful before you start to ask for the huge chunk of BHT hours, which may or may not be necessary at that point.
Thank you. And thank you for sharing your previous thoughts. I think we,
Can I ask a question
Oh.
really quick? I'm sorry. It's Danielle.
oh,
Can we get I appreciate the sentiment and everything. I absolutely love the summer feedback about keeping services and consistency and all of that stuff. But some of the other things in terms of the camp and not starting with support and the things that you're saying about the school, which we agree with, I think I should have. I'm working myself out of a job tattooed on my forehead at this point. But is there some collaboration that Magellan can provide, a document, some kind of outreach to some of these schools, because they are not hearing this at all. They don't understand this process at, in what you're talking about. So is there just something we can get? I mean, we give out the caregiver FAQ about what we can and cannot do, but I feel like if there's some kind of, not necessarily policy switch, but understanding about what we're going to do in terms of the process, is that something that Magellan can kind of generate that we can provide to families and schools and camps?
So I'm going to let, since that's more of a like policy question, I'm going to let Kristen tackle that one. And then I'll give my kind of practice thoughts.
Yeah, I'm totally open to that idea. Obviously, the member caregiver FAQ came from your guys and your suggestions around that. So what I'm hearing, correct me if I'm wrong, Danielle, is having something from us that clearly sort of articulates the expectations that we have for the providers, the members, the service would be helpful. Similar to, not similar to the FAQ necessarily, but in that way.
Well, just explaining, like, we need to give them time to settle in. We can't always start at the high end and expect to titrate. Like, maybe they need to do this, and not even that stuff, but more of like, this is your responsibility. This is your job to take over. You need to have staff available for these kids as part of their free and public appropriate education. Some of the schools are doing that MTSS, but they don't all have that. I think the other thing is it's not the same across organizations. I've had teachers in schools who come to me and say, they have a client who's worse when their BHT comes, but the place won't remove them because they don't have another client to send them to. So there's just like anything that we could do to kind of help this and streamline it and make it more standard. We're still running into the issues, well, so and so does this, why can't you do that? So just anything to kind of help alleviate some of those stressors for us as providers, because I'm just going to be honest, they don't care. They don't care about any of those things you just said. We do, and we're trying, but they really just don't care.
Yeah, the reality of it is that these schools are still telling families you can't, the kid can't be in this classroom without them. Daycares are doing it, camps are doing it. And when the parents look at like, okay, I have to put my kid somewhere this summer, and they said they can't come without immediate BHT support, they don't want to go through, okay, well, you can call, Ocdell. And they're like, I'm not going to do that. I'm just going to call another provider who's going to, I know I talked to so-and-so and they said their provider will do this. So I'm going to do that. I know you guys can't really control that completely, but we're trying to do the right thing and stay within kind of the grounds of, Magellan's expectations. But it's also just like terrifying for these kids and families to be in some of these, like if you go to some of these school districts, it is not pretty. Like it's far beyond, like they're not getting a good education. I know they're not even safe. So it's like, okay, we're going to walk away from this case because they're not transferring skills. So yeah, I know there is the FAQ. So I don't even know what the right answer is, but there is a lot of that. Like it does feel like the burden is on us as providers to give them this bad news and get screamed at and cried to and all these sorts of things, with not a lot of solutions. So
And
Yeah.
I can greatly appreciate all the comments that you had said, and others that may not be sharing their comments. You know, I was in the provider space for a very long time, as many of you know, so I understand. The and the message involves providers being consistent in and of themselves, because you can't necessarily control what another provider is doing. But you can, you know, look at yourself and say, okay, we're doing what we're, you know, tasked to do. And just the ongoing reminder, you know, with the school and with, you know, I would go to the school district like I think it was every couple of years. I also advocate to do an IBHS presentation to a school district, so that the school district had an idea, if they would allow us to come at the begin, like in the August training dates, of what IBHS was, and to do that on a regular basis, to remind them that this is an intense temporary service, to partner with what's happening at the schools, to go in, assess the situation, assess what's going on, relay and implement your behavioral modification expertise to reduce behaviors, increase skills, identify the strategies that are effective a good chunk of the time, not all the time, because kids are kids and they're not robots. And to get the kid on the right track, and then transfer those skills to everybody so that they become the expert, and to sit and to mentor, coach, and support while that's happening. And that takes, you know, that's not 6 months, that's not a year, maybe that's not even a couple years, that takes some time, and we understand that. But to constantly be having those conversations, it hopefully eventually, and I've seen it, eventually can take hold to a point of understanding. The other aspect is as well that if there is a safety and educational obstacle that's not IBHS related, there are advocacy organizations. Patan is a really great advocacy organization, educational advocacy organization at the state level, that I've often given providers that information. Many of you have it. I'm happy to give it out to others. And I've encouraged providers, as well as encouraged the providers to give that information to parents if they feel that their child is not getting what either they're entitled to or what they could be getting, and just to have a better understanding of what the advocacy rights are. Patan can be exceptionally helpful. And just continuing to have the conversation with caregivers and with schools at each level in terms of what is the realistic expectation of IBHS. And it is by no means perfect. Nothing is perfect, and you guys do great jobs, especially in a lot of the environments that they're in, which are not by any means ideal. But you're tasked to do a certain thing within a relatively short period of time, as IBHS is a short-term service, whatever the parameters of short-term might be for a particular child. And then to really emphasize and to continue to talk about that partnership and the transfer of the expertise. And a lot of times that repetition eventually gets through. Other times, realistically, it doesn't. And if you clinically are saying, okay, this kid is in a good place, we've tried to transfer skills and it's not going well, then clinically, you know, there's no need for you to continue to stay there. You've done your job. And if you're having a hard time titrating, or parents are like, you're not leaving, school said you're not going anywhere, then please call us. Care managers are great, and you know, I support them, but they do that great expertise work in helping to work with you as providers to manage some schools and some parents as well who are saying, nope, you're not leaving. Because the flip side of long-term service delivery automatically ends up being dependence, which is not the point. And that's why BHRS was restructured to be more short term, so that that dependence didn't get fostered. I hope that answers something. And again, you guys can reach out feel free to reach out to me at any point.
And I know our conversations around school continue, so I will continue to take these thoughts in, and we can talk even more, obviously, about other additional steps we can do to support other documents that might be supportive in this ongoing struggle. So I appreciate the thoughts and feedback. I did have up here, thank you, Dr. Torres O'Connor. I did have up here again, just in case there's people that are less familiar with the change of prescription process and how the TAR works, just kind of pointing it out. So again, to avoid any confusion, but you have the ability to request something in the middle of a current authorization or make a change, and how really ultimately the TAR would encapsulate all of the units that you would need total between the ones you already have and any changes, additions, things like that, because that's the total number of units that you're going to get as an authorization. And then obviously in the assessment documentation, you have the ability to carve those dates, those hours and dates out a little bit more. So any care managers are very much open to walking you through this so that, you know, before you submit it, so that it's entered correctly and it continues to be clear. So we do have another provider spotlight. I'm happy to report, again, in talking about school support, camp, and all of those processes and things like that. We talked about the ISPT meeting and decided, you know, there was this one provider, well, many providers, but we had a provider where we saw a nice change in the ISPT meeting documentation that was happening. And so we wanted to sort of highlight and asked if they would share their information, maybe their template, and a little bit about how they got to that process. So happy to invite Amanda from Footsteps to talk a little bit more about how they have been working with the ISPT meeting summary process. Hi, Amanda.
Hello.
Hello. We can't see you. Are you trying to provide your video or no?
I have my camera on. I'm not sure what is
Okay.
going on.
Let me see. Okay, I haven't done anything to you, so probably everyone. Okay. While you're figuring that out, I have your PowerPoint, or do you want to try to share your own PowerPoint right now?
It doesn't matter. Either way is fine with me.
Okay, I will pull yours up quick. Oops. Share that.
Sure, it's open, but it's not. Yeah, let me see.
Maybe it's just me, but I can't see. I can't see you, but at least we can see your pretty slides, I think. So
Yeah, our camera's on, but it's not. It's like
it's not showing.
Yeah, it has the light on that it's on, so I'm not sure if there's a button somewhere.
All right, we don't get to see your pretty face. All right, but I'll turn it over to you. Thank you again for being here and sharing.
Thank you for having us. So I want to talk today about our ISBT summary. We used to have an old form. If you want to go ahead to the next slide, we can start there. We used to have an old form that the information in the treatment plan was pretty much copied and pasted into our ISBT summary. It had about like the definition of our goals. It had our short-term, our long-term, and intermediate goals. It talked about the progress and regression and the baseline data. And our ISBT meetings were getting pretty hard. The BCs were saying that they were short and very difficult to get information from our teachers and our school personnel. Our staff pretty much just led the discussion with where they were at with their goals, how they were meeting them, what the needs were, and they really didn't have any input from our school. So we were trying to figure out how we could make that better. We were getting a lot of different peer reviews, and we were starting to discuss the information that they were looking for at the peer reviews. So I had Dr. Hazlitt and one of our BCs were going into a peer review, and we were like, write down some information that they're asking for. What kind of questions are they asking? If we can kind of revamp our ISBT summary to be able to answer some more of those questions that they're looking for. So they attended that next peer review. They wrote down some questions. We met again, and then we ended up attending the IBHS Provider Roundtable on 8/19/25. And Kristen absolutely went through a slide that said about the ISBT meeting as a tool, and it gave a bunch of questions with that. So we took that picture of that slide and we pretty much took the answers that we had gotten back from the peer review with the questions and put them together into a new document that had all the answers, all the questions together in one format that they were looking for. So we ended up taking that new format. We had a trial run with one of our BCs that had a packet upcoming. And they said that the meetings went more smoothly with that. They were having more conversations with the new ISBT. And they decided that, we were going to put that in place as of October 25th. If you want to go ahead to the next slide. So the top of our new ISBT summary does a lot of demographics. I know that's not pictured here, but like the top of it shows the client's name, where they go to school, their medications, some things like that. And then we really get into the educational placement. What type of classroom is the client placed in? What school-based supports are in place? Do they have autistic support? Do they have general education? Are they in emotional support? Do they have speech, OT, that type of things? They talk about what the student to teacher ratio is in the classroom, what strategies currently work, what interventions and or accommodations has the school tried, and what has the client's response been. Head to the next slide. We discuss in the new form, where has progress been seen? Are there any barriers for progress? And if so, how can those barriers be addressed? What are the areas of need and concern within the school setting, and how are they being addressed? Go ahead to the next one. And then we are able to have more of a conversation with, is there an IEP in place, a 504 plan? When was the last day of the IEP review? We discussed the barriers to skill transfer. What does the child need to learn to succeed? How will the school staff reinforce replacement behaviors? What is the child expected to do, and how can the school staff reinforce in a way that the child can understand? We discussed the titration plan. We do a transition plan so that it has the next steps for the provider and for the school, and how we can work together to make sure that this kiddo is meeting his needs and their goals. Go ahead to the next slide. And then we really break down the goal sections to show what the goal is, where they were at with their baseline, what the beginning of their current treatment period looked like, and that includes the intensity, frequency, duration, and then how the progress or consistency or regression has been. Did they make progress? And we really break that down into their intensity, frequency, duration sections there. And it's a short form. It's like 3 or 4 pages long, depending on how much information you put in there, but it really focuses on the questions and the needs of the kids, and it gets the school involved a lot more than what we had originally in place. You can go ahead to the next slide. So in our actual ISBT meetings now, if you want to go ahead to the next slide. This template has been very helpful and beneficial. The school and our BCs have stated that there's more increased communications and conversations and collaboration during the ISBT meetings. The school is able to provide more feedback with us when we are offering them open-ended questions, and they're being asked more questions than just we're going in and giving them the information we're seeing and we're just not really getting any feedback back. When the teachers that know their students are participating in these meetings, they actively engage in discussion. Whereas if you would have a guidance counselor involved in the ISBT meeting, we're really not getting much information because they don't work one-on-one with this kid all the time. The teachers have expressed to us that they feel that their input is valued when we're asking these types of questions and really getting their feedback from what's going on in the classroom when we are there and when we're not there. And then during these ISBT meetings, when we have this stuff laid out, the parents are able to hear what has been working and not working. We're able to discuss what's been attempted with the clinicians and the school and what we can try to meet the needs better. And when with this new form, I can say that we have had a significant reduction in peer reviews. And just being able to give Magellan, the insurance companies, the information that they need firsthand, and not be able to have to take time out of the day to make the peer reviews and have that collaboration meeting. And then I did have an extra slide on this one I didn't send you, Kristen, but it just said thank you for allowing us to present today. And then also I'd had my contact information. If anybody would like to have a copy of our Word document for our new ISPT summary, I am glad to send that out to anybody that would like that. My email is agabelli@footstepservices.com, and I can put that in the chat too, so everybody has it. If you would like to reach out at any point in time, I can share that ISPT summary with anybody that would like it.
Great. And Amanda, we've talked about this before. So not only in our realm, but it sounds like the conversations with the school and the family have gotten to a different level, having this type of structure or the questions that are coming out, right? Was that fair to say? So that, to the point, like Dr. Torres O'Connor was talking about, like that everybody sort of understands their role, and that you are setting the framework of an expectation of this is short term, let's continue to have conversations, what's working, what's not, what's the next steps, and that the family hears it. I feel like all of those can be one piece of this larger puzzle of construction, right?
Yes, that's absolutely true. I mean, I will say that we still have some struggles, with families letting us get into the homes and doing some of like the community work as well, and having the time over the summer to really work with these kids. But we do feel that the school has been able to understand more of our role. The parent understands more of our role in the school setting with these types of meetings that are more informative.
That's great. Thank you so much for sharing. And I know we've talked individually that, the form is actually quite long, and it doesn't necessarily, everybody can sort of pick and choose some of the things, but it's kind of a good guideline. And I know some providers have said, they find it helpful to have a template for their agency, so that there's a little consistency as well across their clinicians. So
yes,
thank you for being willing to share that and talking.
You're
I don't
welcome.
know if anybody, and I didn't look at the Q&A, which was bad on me, but I don't know if there's anything specifically for you in here. No. Okay. I wouldn't know if anybody had any questions. So thank you again.
I do have a quick question,
Yeah.
Kristen, I'm so sorry. This is Celinda Lee from Creative Health. Amanda, that's great information, and I love how you were able to get the school involved and develop a format. Who runs your ISPT meetings? Is that the BC?
Yes, so our BC will get in touch with the school and the mom or the parent and try to figure out a time that works for everybody. And then they will sit down and they pretty much just take our new form and we go down the questions and they start answering the questions as they're filling things in, and the topic of discussion goes from there.
That's awesome.
But at least give them like a baseline. You're welcome. At least give them like a baseline to start the communication with.
Hi, Amanda. It's Dina Huddy from Beth Anna. Can you put your email in the Q&A because the chat is disabled?
Yes, I just did.
Thank you.
You're welcome.
Well, thank you again, Amanda and Footsteps, for sharing the process, their evolution. And we really appreciate it. Sounds like providers are also appreciative of your sharing, and maybe are stimulating some new ideas and thoughts for their own agency, which is great. Thank you again.
Thank you.
All right, let me go back, reshare. Excellent. Okay, next up are some quick kudos. This is our first webinar for the new year, but so there are a couple shout outs that came out as we were digesting everything from 2025, but we have 4 providers who have submitted 100% of their IBHS access surveys, those twice a month things. So major shout out to ABA Consultants, First Children's, the CCIU, and Assist. Thank you guys for doing that, not missing a beat. I know there's a lot going on, and twice a month, seems like nothing, but we do recognize that it is not nothing. So thank you again for everybody that's submitting. Obviously, that access survey goes to a lot of people, and a lot of positive feedback comes from it. So if you haven't heard it directly, let me share that it does come from that. So your consistent responses are appreciated. So thank you. And regarding our clinical measurement tool, or sometimes it's been called the TRR, I wanted to sort of share a high level of some of the data that comes. This is those audits that are happening if you have a certain minimum number of members served, and our care managers are looking at it. Usually it's twice a year, depending on it. And we had talked about this with our QI director early last year, I believe, and kind of went through the process even more so. But if you notice the green highlights, the overall total has had a nice increase steadily over the year, which hasn't always been the case. So I do think that some of the partnership with QI, having more conversations about it, having, some agencies really look at their documentation, figuring out some things as simple as, oh my gosh, we didn't even realize our electronic health record wasn't pulling this whole section of our assessment in. So through that conversation over the last year, it seems like it's had some beneficial results. So we really appreciate that. We hope that this obviously translates to quality and, quality work for the provider, the members that were being served. So thank you all here. Thank you also for doing a nice shift that we threw at you on these updated TARs. Although I, again, hear some good feedback that it's been helpful in your own internal processes, but having that additional piece where it carves out the assessment recommendations as well as what the authorization looks like has been sort of helpful to decrease some of the confusion, validate that there's an understanding of what's being asked for. And you guys have really championed being able to figure out how to do that accurately when, it's a little complicated out there. I get that. But I do hope that it's helpful. It's helpful on our end, and it sounds like it's even been helpful on your end to make sure that all your documents and the request is very consistent. So we appreciate the pivot that everybody did in shifting to this over the last few months of 2025. So thank you for that. A few small clinical updates and feedback. So I just mentioned the TRR, or the clinical measurement tool process. Just a reminder, they generally will come twice a year. We have had some spacing if there was an action plan issued in one quarter. We are waiting a good more amount of time. We're giving it more time to allow for implementation of changes. So depending on how the year falls, it may not be exactly 2 times, but that's the pattern that we have here. So it is a random sampling of packets that are coming in for currently being sort of reviewed within generally that quarter that we're talking about. We have shared the tool. The care managers have access to the tool to be able to share with you. We do hold a packet up and kind of use that tool in a comparison. So it is recommended, and a lot of you guys have taken this upon yourself to do some kind of self-audit. Some of your supervision have been able to look at that, which again is a combination of some regulatory requirements, clinical best practices, etc. So it is a little bit of a combination, and again on a random sampling just to see how things are going. The reviews that happen for medical necessity don't necessarily happen on every single packet. It's not conceivable that our care managers are even going to be able to offer feedback on all the packets and such. So this is another way to have providers get some of that impact or see it, or obviously be able to use the tool yourself and kind of see some of those same things. Again, these are slides that we did share when our QI director came, so we thought let's reiterate some of it. Hasn't been talked about maybe for a little bit on this webinar. So the outcomes of them, again, it's a cumulative average. If all of those reviews cumulatively come out to 76% or above, then you get letter of notification that, hey, here's the members that were reviewed. Here's, sort of, this is the general quarter that was done. Offers a little bit of, feedback, and there's no action plan. Everybody can move on. There's been some, great observations of things that have happened, and you met the threshold. Excuse me. If you hit a 75, again, cumulatively, not just one score, or below, there's a different letter that comes out, and that comes out from our QI department, and it does outline and give an action plan, which basically encourages you to look at each of the areas that had the lowest threshold and be able to say, hey, how are we going to make sure this gets included? And being able to respond to that and put that into a clear plan has been kind of helpful. Again, we've kind of talked through some of those scenarios, figured out some things that are literally IT related that weren't happening. I've seen some really great plans as far as like some tweaking to like assessment tools or some of your templates that can help. Again, you have multiple clinicians coming in and out, new hires, people that have been there a while. How do you communicate something to a bunch of different staff? And some of the templates enhancements have been really, really effective. So appreciate the time and attention to some of that as well. I'm going to start doing this. This was a suggestion that I thought was a great one. So currently we're in Q1, so there are some providers that are in process, based again on the metrics of when you're due, the minimum number of members served, that kind of thing. So some providers are not on here because they don't serve a certain number of members. So just a heads up, these are the providers that we have being reviewed for this quarter. Usually we've now got a good steady rhythm. I think that usually within the middle, so this is Q1, January, February, March. Usually by the middle of April, we have our data collected, and by the 3rd to 4th week, we are sharing the letters of, the results of these reviews. So again, just giving a heads up, I also put an asterisk at the bottom because at this point, our Somerset and Bedford providers and members are not part of this process at this time. So I don't want to confuse those providers that are new as well. So just putting that out there. Again, I'm going to do this every quarter. I think it's helpful to kind of level set and remind providers. So that is our providers for this one. Just also a reminder, we have the updated TARs, as I pointed out. I do want to point out, because I have seen and heard a couple rumblings, the initial assessment TAR is still there. That's what you have to do to register to get your initial assessment authorization, but it hasn't changed. So that process is still there. So I don't know if people are confused because that's the one we didn't have to change. So please continue to use the same one. It's still posted, but it does look the same. So I just want to make sure that people are clear which ones got updated, and then the one that technically didn't get updated but is still active and is still part of our process for getting those initial assessment auths. Just another reminder, because I've had some questions that have come up, and again, we have some newer providers to the network, etc. Recently, kind of around the same time we were adjusting those TARs, we put together this authorization request checklist. So this is a really good tool, especially if you have people who are newer or learning what to submit, or honestly, you don't often do a change of prescription, or, oh my gosh, I almost never have a member switch from Montco to Bucks. Oh my gosh, what do I have to do about that? We tried our best to come up with a lot of these scenarios and put them into this framework. So this is posted on our IBHS provider page. So check here, because we kind of try to outline how you submit it, fax or online, and kind of try to outline the documents that you would need to submit and the process along with that. So check there, and if there's questions from there, certainly the care managers can help you. But I do find that that's a good resource to keep handy, or know where to find it. So just a reminder on that. We've had a few scenarios that have come up lately on the transfer request. So again, not sure who is coming to these meetings, but if you have staff that is in charge of this process, please make sure that they get this information. This is not new. This has been our process for quite a number of years, but for some reason lately, we've had a few providers that have missed this process, and honestly missed an authorization, and were in jeopardy of not getting paid for time. And that's certainly not what we want to happen. So we want to make sure everyone's clear. This is posted in our provider manual as well as one of our processes, but the currently authorized provider would communicate with the new provider, share copies of your packet that's already sent so that they have access to your treatment plan assessment, etc. Send them a letter on your letterhead saying, hey, Joe Smith, who currently has an authorization with us, is transferring to XYZ provider. And we've talked, both providers have talked and said, yes, we mutually agree that this is the date that it's happening. We're ending on this date. They're starting on this next date. That gets put in the letter. That authorized provider does not need to submit a discharge summary, okay? Because what will happen is when the new provider gets started, they are sending to Magellan the letter that you've already sent that says, hey, we mutually agree that this is the transfer date. They're going to create their own letter so that we have one letter from the current authorized and one letter from the new. They should match. They should show everybody's in agreement of the same thing. And then the new provider puts a TAR in that shows what remainder of the current authorization they need, how many units, etc. So, and that TAR does not need to be, it shouldn't be a carbon copy of the original auth, because you're obviously not taking, well, most of the time you're not taking the full auth, you're taking a portion of it, right, for the remainder of the authorization. So you need to figure out what units. So the current authorization then will get ended. That's why you don't need to submit a discharge plan, because we don't want it to look like you discharged as opposed to transfer the authorization of service and care. We've had a bunch of providers that aren't communicating with each other and therefore not necessarily agreeing on a date. So sending paperwork and not necessarily having a further collaborative conversation and saying, hey, I understand that either the family had found them or you found them, but that there's not a real conversation about, hey, a warm handoff. Hey, this is the service goals. Did you get the treatment plan? Do you have any questions? Are we agreeing on the date? Did you get my transfer letter? Is everything okay? Does the family, we've communicated this with the family, everybody on the same page. So that collaboration piece has seemed to be missing, but also this process is not coming through quite as clear. And again, we want you to get paid for the services that you're rendering, and we're happy that you found another provider to provide the support. I just want to make sure everybody's aware of these next steps in order to get that authorization moved over. Again, not a new process, just wanted to validate that. So Availity, again, some of you probably hear this in nauseam, but you have a few ways that you can look up an authorization in Availity. You can punch in the auth number, which as you continue to do those extensions, which are the concurrent requests, the auth number doesn't change. right? It's a one auth number, and the myriad of different authorizations falls underneath it. But you should still be able to view all of the authorizations under that auth number. You can look up a member information, specific members, Joe Smith, find their authorization. And then you have a way to search by your provider ID or your MIS number. So this whole site, I want to see every kid from Magellan that's authorized from this site under this MIS number. And then you're able to search that way. So depending on what it is, the task that you're trying to do, you can look it up that way. I have, we are posting the step-by-step guides. I often share those. I find them helpful. They give a lot of visuals along with the directions. So I'm happy to share those as needed. They're posted there as well. We're at 64% that I saw more recently that are submitting the concurrence as we need them to be, which is finding the authorization that is currently in place and hitting this extension button, which cuts down on your time to actually do it. So the pre-cert, the initial auths take longer than if you're doing a concurrent if you do it this way, because you don't have to re-enter a bunch of the information. You pull up the authorization and you hit the extend button, and it prompts you to kind of change out some of the units and the dates and stuff like that. But some of the other stuff is auto kind of filled, and it really, really saves a lot of time on that way. And we really want to try to get, obviously when we were starting, it was just get them in the system. Some of this will impact our data, right? So if we're trying to pull how long somebody's been in services and we keep getting these pre-certs, some of that is going to mess up the data as well. So I feel like we're at a point where we're going to really start, following up with providers to make sure that you're able to figure out how to do this process consistently so that our data follows suit. I do have some of the quick slides about adding the extension. So you look up the authorization, and if you see here by this number 3, that's what that extend button looks like. So extend, add, it might be a little confusing, but that's the button that you need in order to basically start the concurrent process. And I put a whole bunch of the specific slides so you can see it a little bit better. There's that extend and add button. So feel free, again, pass it along. If you're not the person at your agency that does these, concurrence or availability submissions, please pass this along. I think this is super helpful. And obviously we'll cut some of their time. Our Q2 webinar is going to be Thursday, April 30th from 9 to 11. As always, we don't send an actual invite for the calendar, but we will have it posted at the bottom of our website. Our IBHS provider page always has a flyer with our next one. So once this webinar gets posted, that's when they update the flyer as well. So give us a day or two. And when you see this webinar posted, you will also see the update at the bottom regarding this webinar. And just another reminder, again, not a new process, but if you do get your hold of a written order that you're not necessarily able to act on right now, but there is a written order in place, we ask if you could send the IBHS email box some of this information. We have a quarterly report that goes to the state, and one of the aspects is there any kind of written order that's hanging out there that needs some action, and how long is that taking to get acted on? So there's a tracking mechanism on that. So if you do have access to that information, other than, this was our only way that we could figure out how to get that information to be able to track some of that. So we're still welcoming that information. We would encourage looking at this provider manual as well. IBHS has a ton of different processes, as you're well aware. We do try to put in the provider manual some of the very common the more basic ones, like the transfer. We can't capture all of them because they won't let us take that much room in the provider manual, but I have referred people to the provider manual as having several of these processes readily accessible to you. So I know sometimes it can be a little challenging to figure out where the provider manual is. So I do have the link there so you can access that. That's a really good resource. Again, if you're struggling to figure out a process, claims, retrospective reviews, like, start there, and that usually gives you a good head start. We also have posted the compliance blast. I always like to put that reminder out. So if you maybe don't see them, aren't part of the blast, they're all posted on our Magellan of PA website. So feel free to look at that as well. We do have this video, 5 minutes and 45 seconds, quick overview of what IBHS is. It's good to share with maybe a new setting that you're working with, a new daycare, a new family, so that they get an understanding, quick overview of what the service looks like. And then, as we talked recently in this webinar about, we did develop a caregiver FAQ with some of the providers as well to help dispel some of the myths about things that IBHS can and can't do, what the staff can do, how they work with other systems. And I've heard this can be a good tool, again, to start initiating that conversation, have follow-up conversations about expectations, have something concrete to point to. So again, sharing it with schools, daycares, families can be a helpful tool as well. So adding to your toolboxes there. Again, the online authorization system has a lot of step-by-steps, which I find super helpful to doing a lot of these processes that you're involved in. So there's that link that you have accessible to you as well. I know we've been doing questions along the way. Thank you for holding down the fort. So I do see, oh, somebody answers. The TRR form is not posted, but it can be shared by the care managers. So I think we've kind of kept up to date on that. Michelle, is there anything you think we need to share with the greater group?
I don't think so. I just answered the last question, I think, that wasn't answered, and I don't think it's anything that needs shared with everyone. I think it looks to me like we're good.
Perfect. Again, thank you for...
Kristen, it's Ashley Daniel from ABA Support Services.
Sure. Hey, Ashley.
I did have a question in the Q&A regarding billing codes that I was just hoping to get some clarification on while we were on. I don't know if you want to look at it.
Better to have.
I don't know if there's resources that we can get with a description of the allowable services under each billing code, specifically the 97151.
So
we've had...
Yes, go ahead. Sorry.
Go ahead.
We have been referring, and I know a lot of the BIMICOs are doing this. I'm going to put it in the chat response here. Oops. Specifically, I don't know if I put it under the right one. Hold on. Oh, this is not good trying to do off the cuff, but I have it here. Where is yours? There it is. There you are. ABA, we generally are following the ABA Coding Coalition and such, the normal norms for what is billable and such for the codes at least we have. I know there's some additional codes in ABA world that we don't all have under, the state. So there is some resources and some pretty good information on this website that I just shared with you regarding the 97151, and I'm certainly open to any specific follow-up that you would need if that site didn't.
That's great. And I do see Crystal's response also. Thank you, Crystal. I will send an email to you as well.
Perfect. Great.
I'm sorry, I can't see anything in the Q&A. Like, I don't see any links or anything, because I also had questions about the upcoming ABA code changes. I can't do anything like post a question in there. Can I just ask it real quick?
Sure.
So the
Other people
ABA
are seeing it though, I think.
Yeah, I
Do
think so.
other
It
people
might just
see?
be my issue.
Okay. Okay. I just
But
wanted to make sure.
the ABA Coding Coalition was approved to add 6 new ABA codes as of 2027 and update the definitions of 97151 through 97158 starting January 1st of next year. Is that something that the state is going to also update when that information becomes available later in 2026?
So I haven't heard of this, and I'm a little not sure that that will happen, but I will bring this as an agenda item and a question for at our next meeting, and so that I could circle it back to this group then, if that works.
Okay.
Then
Yeah,
I'll add that.
I can email you the link since I can't put anything in the Q&A.
Okay. Yeah, that's fine.
Just to
That'd
the
be
ABA
perfect.
Coding Coalition that just gives the info.
Yeah, I'll be happy to follow up. Again, I haven't heard anything, so I wouldn't say yes on the change, but I think it's a good proactive question to ask, so I will do that.
And also, because I know some of us in Lehigh Valley were a little behind, Highmark Blue Cross Blue Shield is now requiring authorizations for ABA as of 3/1. Lori from Backyard Treehouse had reached out to them and shared the info that they told us to potentially start submitting auth requests 2 weeks before the 3/1 start date, but from social media and some other providers, I've heard that they're still being denied as not needed. So, that information wasn't exactly accurate. But if I find anything else out, or Lori, if you do, we can pass that on as well.
Sounds good. Thank you. All right. Well, again, thank you. Give me probably early next week, Monday or Tuesday, to get this posted on our website. And thank you again for your time, attention, and for switching and pivoting 2 weeks on the count of my unhealthy gallbladder. So thank you all very much. And I will talk to you later. Thanks, everybody.
Bye.
Bye-bye.
Bye.